behind you. I'm Michael Thase, and I'm here to talk with you about how the combination of bupropion and dextromethorphan fits into an update on the current management of depression. And so I will, let's see, okay. So I'm going to first talk about the current state of the art and our unmet needs in the treatment of depression. I'm then going to spend a hot minute, as we say in the US, to just talk about the role of serendipity in drug discovery, and then how that sets the stage for more planned drug discovery. And then I will spend the latter half of my talk talking about what we know 2 years post-marketing with the combination of bupropion and dextromethorphan in terms of its relatively novel mechanism of action, its nicely established rapid onset of benefit, and it's a very, very good tolerability. And so in the US today, about 95% of the prescription of antidepressants comes from 4 classes of medications. The selective serotonin reuptake inhibitors account for about 2/3 of all prescriptions. And we have 6 of them in the US. The serotonin norepinephrine reuptake inhibitors account for about 15% of all prescriptions, and we have 4 of them. And then the remaining first-line use comes from either mirtazapine, which is primarily used for treatment of the elderly or medically ill patients, and then bupropion, which is the only antidepressant that is classified as a norepinephrine dopamine reuptake inhibitor. And if we look at the state of the art, everybody knows at this point that antidepressants have modest but real benefit when compared to placebo. But of course, in our practices, there is no placebo. And so we get the placebo plus the active ingredient when we make a decision to prescribe. But in relative terms, the placebo effect in our clinical trials accounts for between 2/3 and 3/4 of the effectiveness of the antidepressant. So our patients' own ability to get better, their ability to use a therapeutic relationship to work on getting out of their trouble has more to do with their recovery than the medicine we pick. But for our difficult to treat patients, of course, the patient's inherent ability to recover is gone. They didn't recover with the easy treatments. And so now we must move on and find alternatives for those who develop so-called treatment-resistant depression. I think it is also a fact that it would be so much better for our patients if we could declare victory, if we could see substantial improvement within the first week or 2 of treatment, as opposed to needing to wait 4 or 6 or 8 weeks to see people get better. But the mechanism of action of reuptake inhibitors through dopamine, norepinephrine, and serotonin does not permit this kind of rapid onset of action. We've needed to think about other mechanisms of action in order to solve the problem of treatment-resistant depression and more rapid onset of therapeutic benefit. Now, I'm going to take a 5-minute diversion to talk with you a little bit about bupropion, because this is one of my favorite first-line antidepressants. And I began prescribing this medicine enthusiastically in the late 1980s and have appreciated its novelty for the subsequent, what we're moving on now is 35 years. And as you can see, this medicine is an aminoketone. It is not unlike a psychostimulant in terms of its chemical structure. It just doesn't have avid enough dopamine, norepinephrine reuptake inhibition to be a true psychostimulant. We've had it continuously now since 1989 in the United States. When it came back to us in 1989, there was a reduction in the maximum therapeutic dose from 900 to 450. The modal dose in the United States is 300 milligrams. And in addition to major depressive disorder, bupropion is also indicated for seasonal affective disorder, smoking cessation, and used in combination for several medications that are intended to promote weight loss. I think critically for seasonal affective disorder, smoking cessation, and in combination with other medications, the therapeutic dose moves down to about 200 milligrams, the minimum therapeutic dose that is. I think critically, this drug is complicated and it has multiple metabolites and simple assays of, is it really a norepinephrine reuptake inhibitor? Is it really a dopamine reuptake inhibitor? These things really can't be properly assessed unless you take all four of the metabolites into effect. But what I can tell you with confidence is that bupropion has no direct effect on serotonergic neurotransmission. It has basically no sexual side effects. It has a risk of sexual side effects comparable to placebo. It has essentially no risk of weight gain. You have the risk of living in the United States causing weight gain, but it causes no more weight gain than does placebo. It has the lowest risk of daytime sedation of any of the antidepressants that we prescribe. And it has all of those clinical pharmacological differences and still delivers efficacy that is basically comparable to that of the SSRIs. Now, interestingly, it is used more. It's the number 6 prescribed antidepressant in the United States, so it's one of our top 10, but it is used more often in combination with other antidepressants than it is as a monotherapy. And so this, I think, both reflects some fundamental limitations of this molecule. For example, it does not cover anxiety well, but it may also just simply represent the fact that the SSRIs won the battle. They were widely considered to be the first choice, and bupropion has a nice complementary effect when added to an SSRI. This is a meta-analysis I did of all available studies done, circa 2003 or 2004 when I did this meta-analysis. And you can see that there is not even 1% difference in the efficacy of bupropion. So the SSRIs did not become more widely used because they were better antidepressants than bupropion, but they just got there first and didn't have the risk of seizures that people worried about and so forth. So bupropion is a reuptake inhibitor at the end of the day, but it is the only one that modestly targets norepinephrine and dopamine. So we still need non-monoamine targeted antidepressants, and that does represent an important unmet need, because in the 40 years from the end of the tricyclic era to 2010, there were no more effective antidepressants introduced. You can see the placebo response slowly grew over those 40 years, but the antidepressant response did not grow because you can only target monoamine mechanisms so many times and in so many, in only a few different ways. And so we have been kind of stuck, or at least circa 2010, we were sort of stuck and needed to look elsewhere. And so I think it's key to keep in mind that people do not come lightly in for treatment for antidepressant. They come with some ambivalence and feelings of guilt and so forth. So it's important to keep in mind what our patients think about our treatments when we choose to prescribe antidepressants. The thing they think the most is that our antidepressants aren't good enough, that they don't work well enough, or sometimes when they do work, they have a side effect burden that is unacceptable. So our patients tell us the biggest unmet need in the current therapeutics is for something that works better and differently than that of the SSRIs, SNRIs, and even bupropion as a monotherapy. And this was really, really underscored by the findings of the STAR-D study, in which we saw with each sequential treatment trial, the chances that the patient would improve diminished. And so people went from having a 50-50 chance of responding down to about a 10 or 15% chance of responding as you went from a first line to a fourth line treatment. Every time a treatment failed, there was a new chance the patient would drop out of treatment. And of course, as you know from your practices, if you drop out of treatment, you are more likely to be stuck in a chronic depression. And the trajectory of recovery leveled off. And if you remember your calculus, when a growth curve becomes flat, that's called asymptote. And for recovery from depression, the point of asymptote is reached at about 4 trials across 2 years of treatment. And after that, you've got a 5% per year a chance of recovering. So again, we have the best chance of helping people in the first 6 to 9 months that they come into treatment before we reach this point of asymptote in which depression becomes a truly refractory condition. This is a sort of playful, and you know in both British English and American English that the term shipwreck is used to describe a mess, something that has gone very badly. And attempts to develop new mechanisms of action of antidepressants between 1990 and 2010, over 20 years' time, there were a lot of shipwrecks. And these shipwrecks took major pharmaceutical companies out of the business, out of the neuroscience, the neuropharmacology business. And all of these mechanisms had credible, interesting hypotheses. They were all relevant to the pathophysiology of depression, but none of them led to useful breakthrough antidepressants. And by the time we got to 2010 or so, it wasn't clear if we would ever have a new, different, useful antidepressant. But all along that time, people were interested in the glutamate system, more so at first for schizophrenia than for depression. And we had a readily available intravenous drug that directly engaged the glutamate system, ketamine. And beginning with some accidental or serendipitous discoveries in the late 1980s, early 1990s, people slowly began to consider the possibility that this dissociative anesthetic at sub-anesthetic doses could have a novel, interesting antidepressant effect. And I only have one data slide for ketamine to show you, but I just want to remind you when the first 8-patient study was published on, you can see the placebo response rate here was nil. So this was a group of patients who were not expecting to get better. And then if you look at the improvement across time, we're not looking at weeks. We're not even looking at days. We're looking at hours. And in this first study of intravenous ketamine at about 1/4 the anesthetic dose, 5 out of the 8 patients in this experienced a remission level improvement within 72 hours of having had a single exposure to 0.5 milligrams per kilogram of intravenous ketamine. And of course, the next 20 years has gone into determining if this was real and how we can apply it clinically and so on and so forth. And as you know, in India, as well as in the United States, you can formulate generic racemic ketamine into intranasal mixtures. You can give it IM. You can even give it orally, but it does not work in those other formulations nearly as well as intravenous ketamine does work. And so what ketamine's discovery did was provide us an inconvenient and odd treatment for those that we were having trouble treating. And we now use ketamine in the United States often ahead of ECT. But it hasn't given us a practical, everyday, outpatient, easy to do treatment because none of the non-intravenous forms of ketamine have accomplished that. We do have an intranasal, a standardized, well-developed intranasal form of S-ketamine and of the isomer, one of the active stereoisomers of ketamine, S-ketamine, and we have it available and approved for treatment-resistant depression and major depression with suicidal ideation. But both because of the impact of the pandemic on the delivery of healthcare and issues with pricing and access and equity, S-ketamine has only been a small addition to our therapeutic regimen and has not solved the problem of treatment-resistant depression in our depressed outpatients. So, but the discovery of ketamine did lead to taking known medicines that were either used for other purposes or determined not to be active enough to be developed and so forth, and examining how these medicines interacted with relevant novel neurotransmitter systems, such as NMDA modulation. And one of these old drugs that tested out as positive was the active ingredient in common cough syrups in the United States and elsewhere in the world, and then also sometimes used as a tablet form cough suppressant, namely dextromethorphan. And I think of dextromethorphan as a prodrug more so than a drug itself. And the dose that is needed for cough suppression is about 60 milligrams every 6 to 8 hours. And so because dextromethorphan is mostly a prodrug, it's metabolized in your liver by 2D6 fairly quickly. And most of the work, the cough suppressant work, is done by the metabolite, which is dextromethorphan. And dextromethorphan is way less like ketamine than dextromethorphan is itself. And so the idea followed then that if you could inhibit the metabolism of dextromethorphan, and we have lots of 2D6 inhibitors, some of which have antidepressant effects themselves, you could accomplish making an orally available ketamine-like drug with an interesting additional pharmacotherapy related to the antidepressant and some other chemical actions, such as effects on sigma-1 or enhancement of norepinephrine transporters. And so one of the dextromethorphan metabolism inhibitors that was developed then to see if you could make a combination dextromethorphan metabolism inhibiting medicine that also help facilitate or promote the antidepressant effect came with the addition of bupropion. And now you see why I spent the 5 minutes talking about all the reasons why I like bupropion, because it turns out that at 200 milligrams, 220 milligrams a day of bupropion, you get a level of inhibition of dextromethorphan metabolism that gets it up to the levels that bioavailability is roughly comparable to intravenous ketamine. So this is an accomplishment to have a simple, safe, potentially relatively inexpensive medication that makes available a new mechanism of action for depressed outpatients that doesn't involve intravenous or intranasal delivery. It involves the standard once or twice a day administration of a medication. And one of my favorite psychiatric educators, Stephen Stahl, assumed that if you could equate exposure in the brain between ketamine and dextromethorphan, what would the compounds look like in terms of similarity? And you can see in Stahl's formulation that you actually have a drug that could provide something slightly different than ketamine, but having an effect not unlike ketamine in terms of its inhibition of the NMDA receptor and its facilitation of glutamatergic neurotransmission, its stabilization, if you will, of glutamatergic neurotransmission. And so that's a long-winded and roundabout way of saying that we now have a proprietary combination of bupropion and dextromethorphan in the United States. We've had it for almost 2 years now. And the sweet spot for this is a dose of dextromethorphan that is not much different than the cough suppressant dose of dextromethorphan, 45 milligrams, and a dose of bupropion, not much different than the dose of bupropion approved for seasonal affective disorder and used in weight loss, namely 105 milligrams, taken twice a day to get an effective antidepressant medication. And so the combination daily dose of 210 milligrams of bupropion, 90 milligrams of dextromethorphan are the active medications in this combination medication. The version called in the United States was AXS 305. It has a brand name now. That's unimportant, but you will have a brand name when this drug becomes available for you in India as well. And that is going to be brought to you by Torrent Pharmaceuticals. So as you probably have heard, my Food and Drug Administration, which regulates the approval of drugs, gave this compound, they were interested enough, they gave it fast track processing. They evaluated it based on the promise and the unmet need. And there were two, what we call pivotal studies, unequivocally positive pivotal studies, one called Gemini, the other called Ascend. These were studies of patients with moderate to severe depression. One study required that the patient have pretreatment with bupropion. The other study did not require that. And here is the result of the Gemini trial. And this is reduction in the Montgomery-Åsberg Depression Rating Scale. And as I hope you can see, there is a large and highly reliably statistically significant effect observed after only 1 week of treatment. This is, to my knowledge, the largest 1-week drug placebo difference in core depressive symptoms of any approved antidepressant. The effect levels out between 4 and 6 weeks of treatment. So what you've gotten after 4 weeks of treatment is probably what you're going to get total. And again, it's 210 milligrams of bupropion combined with 90 milligrams of dextromethorphan. And for convenience reasons, and also to kind of continue to promote the fact that you're getting metabolism inhibition as part of what makes this special and what makes this work, BID dosing is preferable to single daily dosing. So that's the Gemini study. And this is the Ascend study. And again, you can see in the Ascend study, the difference was significant at 2 weeks. There was a trend, but not quite as large as in the first study. But remember, this is a smaller study. And larger sample size means that you have the power to see smaller effects more reliably. But the very same findings in the small study as in the large study, and that you got a highly significant effect, in this case, after 4 weeks of treatment, but a statistically significant effect after 2 weeks of treatment that tended to level off between the 4th and the 6th week of therapy. You have very, very low dropout rates due to drug side effects, nuisance level, annoying side effects, some dizziness, some nausea, but very, very few patients drop out because of tolerability problems. And in people who take lots of dextromethorphan for cough suppression, these have more to do with dextromethorphan, the dizziness for sure, than the bupropion or the interaction of the two. And so again, rapid response. Here we're looking at remission rates now emerging reliably by the 2nd week of treatment. And then because remission does take the average person a little bit longer than does response, you see the remission rates continuing to grow out across 6 weeks of treatment. So I was an investigator in both of those studies and in one other acute phase trial in patients with treatment-resistant depression, which was a near miss in the drug placebo difference, and as well in the long-term extension studies. So as an investigator, I prescribed bupropion for 4 years, bupropion dextromethorphan combination for 4 years before it was approved, and I was quick to incorporate it into my practice pattern since its approval. So I want to tell you about two patients from my practice that were treated early on with this shortly after its approval. The first is a woman who has a well, mild's not the right word, who has a less advanced case of treatment-resistant depression. And she had not responded in the current episode, first to escitalopram, and then second to escitalopram in combination with 300 milligrams of bupropion, and then third to vortioxetine. So she is in the original Thase Rush classification of treatment-resistant depression. She is at a level 2. She would be eligible for more advanced interventions, including ketamine, esketamine, MAOIs, TCAs, newer generation antipsychotics, and so forth. At this level, she got duloxetine instead. And when you've already not responded to multiple trials within the SSRI or SNRI class, she got very little improvement on duloxetine. And this is when she came to my practice, and we talked about the advanced interventions. She had several practical reasons why she wanted to at least try one more oral antidepressant, and we went with bupropion dextromethorphan combination. I made the decision to continue duloxetine as opposed to discontinue it. I did not want discontinuation symptoms kind of to interfere with the new treatment that was getting started. And so I added bupropion dextromethorphan on top of ongoing duloxetine therapy, but went a little slower with the upward titration from one tablet a day to 2 tablets a day. And she reported recognizable symptom relief within the first week or two, and then at the 6-week level reported a full and complete remission, and said that she was better than she had felt in years. She at the 2-month follow-up, she had been able to come off the duloxetine, and she continued on 1 tablet twice a day of bupropion dextromethorphan combination, and she was a very, very happy patient who had had the best possible response. If you think about a response as a 3-legged stool, you have quality of life, symptom reduction, and freedom from side effects. And she achieved all 3 legs of this stool to base her recovery on. The second patient was a man who did not have treatment-resistant depression. And what he did have was a good response to venlafaxine in his first lifetime depressive episode, but he could not have an orgasm on venlafaxine. He could not ejaculate. And he discontinued venlafaxine several years before he came in to see us because he found that sexual side effect to be unacceptable. He stayed reasonably well then for the next couple of years, but bad things happened in his life, and his wife left him, and they had a painful divorce, and partly because of the painful divorce's impact on his quality of life and his ability to focus on his work. What he thought was a sure thing, an early promotion in his law practice, which would have led to more financial security and some improved working conditions, and a chance to then be part of the most elite group within his practice. His promotion was postponed. He was passed over early promotion. This was not the end of his relationship with this firm, but it was a really disagreeable event that happened to him. So Freud talked about the importance of love and work. In 2 years' time, this man's love life and his work life were in turmoil. So he got depressed. He had a relapse. Because of his sexual side effect with venlafaxine, vilazodone was tried as the next treatment. Um, he did not get one bit of improvement on vilazodone. And I don't recall if he had any sexual side effects on it or not, but it didn't matter because it didn't work. And so this is when he came to my practice. We had bupropion, dextromethorphan. I was confident he would not have sexual side effects with this medicine. We described it. I explained how it differed from venlafaxine and vilazodone, and he was enthusiastic. He had very little enthusiasm. He had an anergic, hypersomnolent, sluggish depression, but he was enthusiastic about trying this particular medication. And we started out 5 days on the 45, 110. We then went to twice daily at that dose. He had a full response by 4 weeks, symptom improvement by 2 weeks, no sexual side effects, and was fully remitted. I don't do the Montgomery-Åsberg in my practice. I do the PHQ-9, but his PHQ-9 was 4 after 6 weeks of treatment. That's within the normal range. So those, this medicine for people who have had one or another misadventure with other antidepressants, this medicine has, I think, about a 50-50 chance of working. And that is as good as any oral medication that we have to offer. So it really does belong in my treatment hierarchy, and it belongs ahead of more advanced treatments such as TMS, ketamine, and of course, ECT. I do not think it should be limited to treatment-resistant depression. I think it could be used earlier. As you see down in my last bullet point here on this slide, I can't use it first line in the United States because of cost concerns. In the United States, generically available antidepressants are very inexpensive, and branded medications are considerably more expensive. And so for many of my patients, I still need to do a generic treatment or two before I can move on to this. That is not the case in your practices. And this medicine is approved for first-line use in the United States. It really can be used as a first-line medicine. The early onset of benefit is real. That is a fact. It's been replicated. We see it in our patients. This is a real advantage of this medicine, and it's because it works in a different way. It really also works in a different way in terms of side effects. You don't see sexual side effects. You don't see weight gain. You seldom see daytime sedation. Because it is different enough from ketamine, esketamine, and because it is orally administered and you do not see rapid rise in blood levels, you don't see dissociative or psychotomimetic side effects. People can drive the day they start to take the medicine. It is not really abusable, no more abusable than dextromethorphan containing cough syrup is abusable. And I really am delighted that we have this medicine. It's been an important addition. So let me move on to your question. Psychiatric therapeutics to lessen the world's public health burden with major depressive disorder is that our current first and second line therapies only treat about 2/3 of the patients who need to be treated. The serendipitous discovery of IV ketamine's rapid and unique antidepressant effects opened the door for considering other pathways to treatment of depression. And unlike the case with many other novel pathways studied since 1990, this pathway has already borne fruit, with the first oral medication being the combination of bupropion and dextromethorphan. This is truly a novel, useful, well-tolerated antidepressant, and I'm glad to hear that you will soon have it available for use in India. So thank you so much for your kind attention. I look forward to your questions.